This is a grade 2 spondylolisthesis on a patient who traveled all the way from Virginia to us in Minnesota to get the surgery done. And as you see, we are dealing with a grade 2 spondylolisthesis. This is my Jamshidi on the pedicle of the 4, just as a marker. I debated to include L4, 5 or not, but this looked good in all views, including CT and MRI. As well, there is no foraminal stenosis, even though patient does have a little bit of L4 symptoms. But we decide not to approach that disc. So practically at this point, I'm putting my needle on the pedicle after I have my marking on the pedicle of the L5. Then I get bone marrow from the pedicle of the L5. Then I try to approach the disc. And as you see here, this is much longer approach than usual. The surgery for us for one level is usually 35 minutes. This surgery was about 55 minutes. So it's significantly longer because we had to take care of this severely spondylolisthetic level. Here I'm trying to approach that, but it just doesn't give me a good silent signal. But finally I'm able, with dropping the hand and going more horizontal, to get a good window in the axilla of the L5 S1 nerve root. And then, as you see, after 2 or 3 passes, I'm able to get to the disc. Now, it is very hard to go around the osteophyte. I use a technique which I call directional K-wire placement. You see here the coker. This is a coker. The coker is holding the K-wire, and the K-wire has a small little bend. And I know which direction is going because the way I put the coker on it. So I'm able to literally use the directionality of the K-wire. As you see here, is bending toward the disc here. And then once I enter the disc base, I have obviously the lateral. This is the lateral view. I have the AP view as well. Once I pass the disc, now I'm going to turn the coker and direction it to this other direction. So as you see now, the direction changed. And here, I'm able to enter the disc. You have to adjust for the trajectory. Here you see, this trajectory would bend the K-wire. So I adjust for that and pull it a little back actually to enter the disc in a more favorable trajectory. And then, as you see it opening up, sucking air, that you see that space is more available and visible now. And I completely pass actually to the other side, to the dilator. And here we see that the disc, this is a 1 centimeter, 10 millimeter tube. And you see where the bone was on bone, now there is a 10 millimeter distance between the end plates. Now at this point, we perform a discectomy, prepare the end plates, and pack it with tricalcium phosphate, and here the cage is going in. If you pay attention, the tube is removed, the K-virus is reinserted, and over the K-wire, the disc space is approached and the cage is placed. And here you see a significant opening of the L5 S1 space. And at this point, we approach the pedicle of the L5 on the left side first. Then we go ahead and put the Jamshidis and the K-wires in the S1 on both sides. This is a device we call decorticator. They eccentrically come from inferolateral to superomedial and grind the surface of the facet, and we pack it with tricalcium phosphate. Here you see the screws are being placed, and as well you see that after the screws are placed, I stimulate my screws up to 25. The left L5 screw gave me a signal at 10. It's still okay, but because of the dispersion of the energy, my own personal threshold is 15. Below that, I use my judgment, but here I'm after I put all the screws in, I actually remove the left S1, reapproach it, go a little more cranially, and reinsert it, and then I check it, then I'm good up to 25. Here you see that all the screws are being placed. Then here the Jamshidi, after the first screw is left S1 is removed and then reinserted. And I'm at this point ready to put the rod in. In a one level, or when the distance between the screws are less than 5 centimeters, I actually use the 90-degree inserter. Above that I use the curved inserter, and I go from up to down and pass under the fascia. But for a one level, mostly when the distance of the screws are less than 5 centimeters, I just connect those two screws, cut the fascia between, and then pass the rod from inferior with the 90-degree inserter, and then I sew the fascia and sew the skin with subcuticular 2 Vicryl, and then apply Steri-Strip. So surgery went well. I just saw the patient. She actually is awake and she has no nerve problem. She had previously radiculopathy that she didn't complain to me right now, but she's still a little sleepy. So I check on her in a little bit.